Well, good day, everyone. My name is Steve Gittleman from the Pediatric Endocrine Division. Welcome to Pediatric Grand Rounds. Um, Today is a little different kind of presentation, and it's my honor to introduce the Melvin M. Grumbach Award today. And this is awarded each year for a fellow in the department who's exhibited excellence in research during their time in fellowship. So I'm going to start with an introduction of this named award and my former mentor, Mel Grumbach. And so Mel started out as a superstar in his discipline of pediatric endocrinology. He got a lot of amazing awards, a lot of notable publications that changed the field. But that's was kind of the beginning of his career. He kind of moved on to someone who was very interested in trainees and led the department here. So it's sort of like that Steph Curry, Steve Kerr relationship. And here's a summary of the different positions that Mel held over the years. What's highlighted here is he was the chairman of this department for 20 years. At the same time, he had some major leadership positions in pediatrics as well as pediatric endocrinology and endocrinology at large. The other remarkable thing about Mel was he stepped down and moved into an emeritus role, but he wasn't around for just a year or two. He was here working closely with us in our division and in the department for 22 years after he stepped down. So he had quite a remarkable career. And one thing he was very proud of is what happened to trainees. And this is just a reflection of the pediatric endocrine fellows and where they went following their career here. I probably need to update this slide to show what how he helped advise and support trainees across many other divisions here. I see Charlie Irwin in the audience, and of course, he was one of Mel's early appointees. So he could give his own separate lecture on interactions with Mel. So let me talk for a minute about the Grumbach Award. We're in our 37th year. The list of prior awardees is kind of like a who's who of pediatric physician scientists. I'm sorry that the font's so small here, but these are an amazing group of people who have gone on to do amazing things. Some of them have stayed here. Some of them have moved on to other places in academia or industry. It's quite a notable, accomplished group. So each year, our awards committee has quite a challenge because we have such productive fellows here. So part of the challenge is they're doing such amazing work, and the work's so varied across basic, translational, clinical research. So that's part of our challenge, is to figure out how to pick out a single best awardee. To announce this year's winner, this is a fellow from the Adolescent Medicine Division, Anoushka Sinha, and she introduced us to a very different type of research in narrative medicine. And I think one of the interesting things about Anoushka's career path is there's this through line from an interest as an undergraduate through her training, and she'll tell you more about that in her lecture today. Just brief background on her bio. She got a BA in Spanish, English, and American literature from Middlebury. I'm not sure that constitutes a triple major or a single major. She then moved to Columbia, where she got an MS in narrative medicine and stayed on there to receive her medical degree and complete her pediatric residency. And then fortunately for us, she came west to join the adolescent medicine program, where she's continued to pursue this interest in narrative medicine, both in her clinical work and her research work. So the title of her talk today is Narrative Medicine from Education to Clinical Research.
Hi, everyone. Thank you for that generous introduction. I'm Anoushka Sinha, and I'm truly honored to be here. Today, I will be presenting on narrative medicine from education to clinical research. This presentation entails work I've been doing over the past several years, projects that span medical education, digital innovation, and adolescent clinical care. I'm especially grateful to be delivering this award as part of the Grumbach Award, this talk as part of the Grumbach Award. It's been a privilege to engage in research that feels scholarly and deeply human. And I hope to share some of that spirit with you today. I have no conflicts of interest to disclose. And here's a brief overview of what we'll be covering today. I'll begin with the foundational concepts of narrative medicine. Then I'll walk through a series of research projects I've been involved in, covering medical education and clinical care. And then I'll end with a brief discussion of future directions. Before diving into definitions, I want to open with two early experiences that shaped my own understanding of narrative work in clinical care. During medical school, I created a project called The Waiting Room, a space for self-expression, as part of our medical school's primary care scholars program. It took place in a pediatric clinic waiting room in Harlem, where we invited children to shape the space through art and storytelling. It offered an opportunity for patients to share of themselves and transform an otherwise blank transitional space into one of presence and expression, adorning the walls of the waiting room with their artwork. This work was published in Pediatrics, profiled by Reuters, and reshared by outlets including the New York Times. During residency, I launched ChoniCore, a podcast inspired by StoryCore, where adolescents with cancer and their caregivers engaged in guided, recorded conversations about identity, legacy, and hope. We found improvements in both groups' resilience and psychological distress after participating in this program. These projects grounded me in the power of and appetite for storytelling in medicine. And that brings us to what narrative medicine is. This quote from Rita Sharon, who established the field of narrative medicine, offers a powerful foundation. Narrative medicine is medicine practiced with the narrative competence to recognize, absorb, interpret, and be moved by stories of illness. I appreciate this definition because it goes beyond passive listening and emphasizes being moved emotionally, intellectually, and ethically by what patients share. In a time when healthcare can often feel rushed, fragmented, and protocol-driven, narrative medicine allows us to slow down and bear witness to the lived experiences behind the clinical data. It helps us to become more present, more curious, and more attuned to what healing actually requires. This slide reflects the historical reality in which narrative medicine emerged. At the turn of the 21st century, medicine was becoming increasingly bureaucratized and dehumanized. Care was shifting toward efficiency and productivity at the expense of presence and relational depth. That impersonalization of care began to erode the clinician-patient relationship. Physicians, under increasing pressure and emotional strain, experienced rising rates of burnout. In turn, burnout made it harder for clinicians to stay emotionally connected to their work, leading to detachment and moral fatigue. As patients' voices were lost in the system, so too was their autonomy. And predictably, the loss of narrative space had unequal consequences. Marginalized patients, those already navigating structural disadvantage, were more likely to be silenced, dismissed, or misunderstood. This cycle of depersonalization, burnout, loss of voice, and inequity became self-reinforcing. Narrative medicine arose in direct response to this cycle. It provided a structured, scholarly, and deeply human approach to reclaiming attention, story, and relationship as clinical competencies. In thinking about how we teach and apply narrative medicine, I want to briefly mention a paper I had the opportunity to co-author for publication in academic medicine, titled Bringing Home the Health Humanities. In that paper, we explored how three principles, narrative humility, structural competency, and engaged pedagogy, can ground narrative medicine in both theory and practice. So I want to take a moment to walk through each of these. Narrative humility is a term coined by pediatrician and our senior author, Sayantani Dasgupta. It reminds us that we can never fully know another person's story and that we must approach each patient encounter with curiosity, respect, and a willingness to be changed by what we hear. It's not about mastering the patient's narrative, but honoring its complexity. Structural competency, as described by Metzel and Hansen, is the trained ability to recognize how social, political, and economic forces and structures shape health outcomes. In narrative medicine, structural competency includes listening for what's missing in the story, what's been silenced by systems, policies, or structural violence. And finally, engaged pedagogy, drawn from bell hooks, calls for a relational approach to teaching and learning, one that centers vulnerability, mutuality, and co-creation of meaning. In narrative medicine spaces, this often looks like faculty and learners writing, sharing stories, and reflecting side by side. Together, these principles remind us that narrative work is not just about empathy. It's about equity, justice, and shared humanity. This slide gives a broad overview of how narrative medicine has been used both in education and in clinical research. On the left, we see its integration into health professions education. At Columbia, where the field was born, students take required seminars in narrative and visual arts, and electives range from prose and poetry to photography and theater. At UCSF, the Healer's Art, a course developed by Rachel Naomi Remen, invites first-year students to reflect on meaning and purpose in medicine. Reflective writing programs like My Life, My Story, which originated in the VA system, allow students and residents to co-create patient narratives during clinical care. And that's part of a requirement in the medicine clerkship for UCSF students. Narrative work has also fostered interprofessional collaboration. Programs have brought together trainees from medicine, nursing, and social work to share stories and build mutual understanding. Journaling projects, interdisciplinary rounds, and Schwartz rounds all offer forums for shared reflection and emotional processing. On the clinical research side, narrative interventions have been used across a range of patient populations. As just a few examples, in oncology, breast cancer storytelling groups support emotional processing. In HIV care, narrative interviews and digital storytelling build agency and reduce stigma. In nephrology, patient illness narratives support shared decision-making. In cardiology, storytelling has been used to reduce anxiety before procedures. And in palliative care, narrative interviews support legacy building, identity affirmation, and meaning-making. This table highlights some of the key outcomes that have been observed from incorporating narrative medicine into health professions education. First, narrative work enhances communication and team building skills. It also encourages perspective taking and reflection. Learners become more aware of their own biases, values, and emotional responses, which helps them connect more meaningfully with patients and colleagues. Promoting empathic behavior is perhaps the most well-known outcome. Students and clinicians consistently report increased empathy after narrative training. But narrative medicine doesn't stop at emotional resonance. It has also been shown to detect or even mitigate burnout, providing protected space for meaning making and emotional processing. Pedagogically, narrative methods augment clinical teaching by drawing attention to complexity, ambiguity, and the patient's voice. They also provide opportunities to wrestle with ethical dilemmas, where there may not be clear answers, but narrative understanding is essential. So in short, narrative medicine isn't just about being nice. It builds durable, translatable skills that strengthen clinical practice and team culture. This table summarizes some of the outcomes seen when narrative medicine is used as a clinical intervention. We see consistent improvements in emotional well-being, self-compassion, and quality of life, particularly in populations facing chronic or life-limiting illness. Narrative interventions have also improved communication, both between patients and their families and between patients and healthcare providers. These conversations often bring clarity, closure, and stronger alignment in care goals. In palliative care, we see reductions in loneliness and improvement in patient sense of connection and community. In cancer care and chronic illness, storytelling has helped patients reclaim a sense of identity and control over their illness experience, countering the objectification that can sometimes come with medical treatment. We also see tangible behavioral outcomes. Patients who engage in narrative work show improved adherence to treatment and more proactive management of risk factors. And in substance use disorders, narrative approaches have reinforced motivation for long-term recovery. Together, these outcomes reflect the dual impact of narrative medicine. It strengthens both the emotional and behavioral dimensions of care. This slide gives a sense of just how rapidly the field of narrative medicine has grown. A simple PubMed search for narrative medicine shows that in 2004, there were just 97 results. Last year, that number had jumped to over 7,700. That growth reflects increasing recognition that story matters, not just as a reflective practice, but as a core element of patient care, medical education, and research. It also mirrors an expansion in who is participating in this work. We're seeing narrative medicine applied across specialties, disciplines, professions, training levels, and care settings. And it's being taken seriously, not as something soft or optional, but as something essential. This slide highlights a set of reflective essays I've published over time across journals like The Lancet, JAMA, Academic Medicine, and Pediatrics. What's striking is that each of these major medical journals now has a dedicated section for narrative. Perspectives, arts and medicine, intersection, healing arts, that in itself says something powerful, that storytelling has been recognized as a legitimate academic work worthy of peer review, citation, and serious engagement. In these essays, I've written about identity, moral uncertainty, grief, and literary parallels in clinical care. Collectively, they represent and reflect how story can deepen how we teach, learn, and practice medicine. I wanted to take a moment to read an excerpt from my most recent piece that has a special place in my heart due to its focus on adolescence and dialogue with one of my favorite physician poets, John Keats. Adolescence is a time replete with dialectics, growth and instability, reliance and independence, hope and disenchantment. In my clinical practice, I try to sit with these oppositions and resist the urge to reduce or resolve them prematurely. Keats wrote to Reynolds, "Let us not therefore go hurrying about and collecting honeybee-like, buzzing here and there impatiently from a knowledge of what is to be arrived at, but let us open our leaves like a flower and be passive and receptive." The patients I meet face daily wins and losses, pose questions without easy answers, and experience understandable angst as they reckon with the cognitive dissonances endemic to our society. Keats wrote to his brothers that there is nothing stable in the world. Uproar's your only music. I believe it is possible to help our patients cultivate an ability to withstand these pressures so they can determine and grow into the answers for themselves. This endurability is crucial to developing the confidence to negotiate and overcome the challenges that beset any adulthood. Let's shift now to how I've studied narrative medicine in educational contexts. This next set of slides includes projects that I led during residency and fellowship that use narrative medicine as a formal intervention, tested not just anecdotally, but through structured research. Each project reflects a different context: peer-to-peer facilitation, cross-site collaboration, and digital delivery. What they share is a focus on building identity, connection, and reflection among learners, especially at times when those qualities are most under threat. This slide introduces one of the first formal research projects I led during residency, The Forest and the Trees, a narrative medicine curriculum by residents for residents, which we published in Pediatric Research. It was born from a need we were all feeling: heightened stress, isolation, and a real hunger for connection, especially during the height of the COVID-19 pandemic. We designed a peer-led narrative medicine curriculum specifically for pediatrics residents, aiming to create a space for reflection, community, and growth without needing external facilitators or intensive resources. COVID intensified stress and burnout. At the same time, we were seeing growing interest in peer teaching and support as core components of medical education. So our objective was simple: implement and evaluate a narrative medicine curriculum led by residents and tailored for residents. We wanted to see whether it could support reflection, connection, and professional development. We ran 7 one-hour workshops across the academic year, held every 6 weeks. I facilitated the sessions and trained 3 co-residents to co-lead using narrative medicine methods. Each session included a short reading or observation, reflective writing, and open discussion. 15 residents, 5 from each PGY level, were recruited to be interviewed about their experiences. We conducted these interviews over Zoom and analyzed the transcripts using thematic analysis and deduce. We identified 3 core themes in the interviews. First, reflection on identity, both personal and professional. Residents used the space to reconnect with their values and reflect on who they were becoming as physicians. One said, "It's not just about understanding our patients, which is so important and helps us in our day-to-day management and our medical decision-making, but then also taking the time to reflect on yourself personally and how you're able to practice medicine." Second, connection to others. The workshops created a sense of community, especially for interns. One said, "Hearing my co-residents talk about their experience made me feel more confident and validated as a physician, and I feel less alone and more like one of the group." Third, a reconceptualization of medical practice. One resident, for instance, talked about how narrative helped them hold on to broader, more humanistic approach to medicine, saying, "I think there's this time in medical school where you're starting out and you're like, oh, of course, I'm always going to feel the perspective of the patient. And it just happens when you're busy, when you're tired, when being a doctor gets so much a part of your identity, even the most empathetic people can get caught up in that. And so I think this brings it back around to thinking about medical issues like death and illness and whatever else, but through a non-medical perspective." So what did we take away from this? First, feasibility. We successfully embedded a narrative medicine curriculum into our residency structure, which has been sustained. Second, impact. The workshops promoted well-being, community, and reconnection with the meaning of medicine. And third, peer facilitation. Having residents lead the sessions reduced hierarchy and allowed for more honest, vulnerable conversation. Our biggest limitation was size. We were a single program with a relatively small group, but the consistency and strength of the themes showed us that something meaningful was happening. Building on that model, my next project here at UCSF tested whether a narrative medicine curriculum could be shared across programs. This work, which I had the privilege of leading as senior author alongside 2 medical student mentees and my mentor, Dr. Buckaloo, is forthcoming in the Journal of Graduate Medical Education under the title "Perceptions of an Inter-Residency Narrative Medicine Curriculum." The visual abstract here summarizes the paper, but I'll walk you through the details. Many training programs recognize the value of narrative medicine, but lack the resources or trained faculty to implement it locally. Our objective was to see whether a shared curriculum delivered across 2 pediatrics residency programs could offer similar benefits to an in-house model. We held 50-minute workshops monthly from July 2023 to July 2024, embedded in the conference curricula at UCSF Mission Bay and Children's Hospital Oakland. We conducted 2 focus group interviews, one at the midpoint and one at the conclusion of the curriculum, with residents who had attended at least 1 workshop. The discussions were recorded, transcribed, and thematically analyzed. 3 key themes emerged, which were quite familiar to the prior study. First, residents described the workshops as moments of reconnection. One said it reconnects you to your humanness in the middle of the day. Second, they reported strengthened relationships with both colleagues and patients. As one resident shared, "The workshops always remind me to stop and pause and really listen to patients." Third, they appreciated that their institutions prioritized this kind of work. One participant said, "It makes me feel better about the program that they're willing to create space alongside other curricula to prioritize this type of learning and reflection." This project reinforced the feasibility of inter-residency narrative medicine. Even without shared physical space, residents valued the opportunity to reflect together. They expressed gratitude that narrative work was built into the workday, not as an extra burden, but as a part of how we learn. And they appreciated the chance to humanize their clinical practice through literature, art, and shared dialogue. Ultimately, this work suggests that narrative medicine can scale, not just within programs, but across them. This next slide introduces a current project that I'm co-leading with Dr. Roxanne Almaz, a developmental behavioral pediatrician. It's called Narrative Medicine Circles, and it brings together faculty, fellows, and staff from across child-focused departments within the Pritzker building. Despite sharing the same physical space, many of us work in silos. This initiative aims to build deeper cross-disciplinary collaborations through shared reflection. We're hosting 5 one-hour in-person workshops between June 2024 and next month using poetry, reflective writing, and facilitated discussion. The sessions are designed to be grounding, generative spaces where participants can pause, connect, and reflect. We're collecting pre- and post-survey data using the Professional Fulfillment Index to understand how this work affects burnout and fulfillment. And we see this as a sustainable, scalable model, one that I'll continue to grow in my faculty role. Another direction I've taken this work is toward digital innovation. This is our UCSF virtual narrative medicine platform built to support reflection and connection across disciplines and training levels. This site is live and accessible via the QR code, and it's still a work in progress. It's a project I'll continue into my faculty role, building on this pilot to grow its reach and functionality. Throughout this section, I'll have the QR code on each slide linking to the website so you can explore it at your leisure. We know that clinician burnout remains critically high across specialties, and while narrative medicine has been shown to improve empathy and well-being, it's often delivered in traditional in-person formats that aren't necessarily scalable. The idea behind the digital platform was to create a flexible space that could complement our synchronous workshops, providing additional opportunities for asynchronous engagement, not just for those in pediatrics, but for the broader UCSF clinician community as well. So the purpose of this pilot was to create a virtual narrative medicine platform offering resources for reflection, supporting clinician connection, and evaluating usability and perceived value. To build the platform, we curated content across 6 genres, including poetry, prose, painting, sculpture, music, and film, and over 40 themes aiming for wide and inclusive appeal. The design emphasized flexibility. Individuals could engage asynchronously, while site leaders could easily pull materials and prompts to introduce reflective activities at their own programs. For the pilot, we recruited UCSF trainees and faculty across multiple disciplines through email invitations and departmental outreach. After engaging with the platform, participants could complete post-surveys to assess usability, engagement, and perceived value. Here you can see the gallery, how it's organized by genre and theme using drop-down menus. And of note, the gallery is, as it says, exclusively accessible to the UCSF community, with all comments securely protected behind my access to ensure they remain private and visible, not visible to anyone outside UCSF. I also want to highlight a new incentive. Participants who post a reflection to the gallery or complete a 5-minute feedback survey are eligible to receive a $10 gift card. By posting 5 reflections and completing the survey, you could get $60, and you would really help us understand the experiences of the platform and how to improve it. Here, you can see an example of a reflection posted under one of the gallery pieces, shared here with the author's permission, Helen Pugh, who's a wonderful collaborator. I'll just read what she posted. This painting makes me think about how universal certain milestones are in life. The joy of watching a child grow is captured here in 1890 as much as in a picture I took yesterday, or when I see my patient walking down the hall for the first time with physical therapy. Those first steps symbolize so much, even when it's not your own child, and there is so much potential captured in those moments. Users can post and reply to each other's comments within these gallery pages. In terms of site activity, since the website was made public 5 months ago, we've had about 1,200 visits, resulting in 4,800 page views with 625 unique visitors. Our survey's results so far have been very encouraging. 100% of users found the platform easy to navigate and would recommend it to peers, and 92% found no technical issues, found the content relevant, and that it prompted meaningful reflection. There were also short answer questions that have helped us understand impressions and make improvements to the platform. Responses to the question, one feature of the platform you find most valuable, included getting to see the team and all the different folks across departments interested in this work, curated examples of narrative medicine, the teaching guide, and summarizing different narrative medicine activities and events all throughout UCSF, bringing silos together. Altogether, our results suggest strong usability and perceived value, even with a relatively small pilot cohort, and highlights a potential interest in structured yet flexible reflection spaces. So our initial findings suggest that a virtual narrative medicine platform can successfully expand access and relevance across disciplines and specialties, and our preliminary feedback suggests usability and perceived value. The next steps include conducting a thematic analysis of participant reflections to better understand engagement patterns. We also are aiming to increase survey participation and reflective postings through the incentives I mentioned, as well as more structured invitations. Longer term, we envision this platform being woven into additional residency programs, fellowships, and interprofessional education efforts, helping to normalize narrative reflection as a key part of clinician development and community building. Now we'll shift to narrative medicine in clinical research. The next few slides focus on projects that use narrative work, not just for trainee development or clinician reflection, but directly with patients and families. These projects explore how narrative interventions can support identity formation, treatment engagement, emotional resilience, and shared meaning in the face of illness. They include a reading program, a narrative-informed digital tool, and a group-based intervention. I will start with Turning Pages, a reading program we launched to support adolescent mental health through access to literature during clinic visits. We recently published this work as an advocacy case study in Pediatrics. We all know that the COVID pandemic exacerbated the ongoing adolescent mental health crisis by disrupting connections to schools, communities, and primary care. Reading has been shown to support mental health by fostering identification with narrative situations or characters and promoting empathy. Reach Out and Read is a well-known national early literacy program endorsed by the American Academy of Pediatrics that provides books to children at well-child visits up to the age of 5. Based on this model, we developed Turning Pages, a program designed to enhance the clinic experience for adolescents by offering books during annual physicals in our primary care clinic. Patients and clinicians recommended books that were meaningful during their adolescence, and we partnered with Christopher's, a wonderful local bookshop, to curate a broad and inclusive collection. At the start of each visit, MAs invited patients to select a book and offered a bookmark with an optional survey assessing program impact. In the first 9 months, we distributed 295 books. Patients and families expressed excitement and gratitude for the program, and several clinicians reported using the books as a starting point for richer discussions with patients. Of the 65 patients who completed the survey in those first 9 months, 98% appreciated getting a book, 81% felt it improved their experience, and 68% felt more connected to their medical team as a result of the program. Comments on the survey included excitement for the following year's physical, feeling welcome because of the program, a hope that it expands to other UCSF locations, and one patient wrote, "This was such an unexpected gift to pick a book at my visit. I really needed something like this now. It was a beautiful, uplifting surprise." Our low survey response rate limits generalizability, and we recommend that other clinics intending to measure outcomes integrate the survey process more seamlessly into clinic workflows. Institutional support and positive feedback have ensured ongoing funding for the program. Our data suggests that adolescents appreciated the addition of Turning Pages to their clinic experience, and the program may serve as a valuable model for dissemination to other clinical settings. As a next step, we've created book plates featuring clinician headshots and biographical details in an effort to strengthen patients' connection with their medical team. The next project I'll share is Inspire, an NIH-funded initiative led by my T32 mentor, Elizabeth Ozer, who's a psychologist here, and James Lester, a computer scientist at NC State. Inspire is a multidisciplinary collaboration across adolescent medicine, behavioral science, computer science, and health communication. I've been fortunate to be part of the team helping develop and refine the narrative components of the intervention. Inspire responds to a major gap in adolescent health. Very few digital health interventions have been successfully integrated into primary care for this age group. There's a real opportunity here, extending the reach of the clinician through personalized, narrative-based digital tools that promote behavior change and improve engagement. The overarching goal of Inspire is to design, implement, and evaluate a narrative-centered behavior change system that supports preventive health among adolescents, especially in the moments before or after a clinical encounter. The intervention is a digital narrative game with a mystery-based plot. The teen protagonist wakes up after a house party with fragmented memories and must piece together what happened. As the story unfolds, users navigate interactive social scenarios, choosing how to respond to peer pressure, risk, and relationship dynamics. The goal is to build competence and practice decision-making in a relatable, low-stakes environment. The storyline and interface have been iteratively developed with input from hundreds of adolescents to ensure authenticity and engagement. I discussed this work in a piece published last year in JAMA titled Narrative Play, Promoting Adolescent Health with Interactive Games. The essay explores how narrative gaming can offer a meaningful framework for health promotion, especially for youth. These tools meet adolescents where they are, immersed in story, choice, and identity exploration. And they let us reimagine what prevention can look like, not just information delivery, but emotional and narrative engagement. We are currently working on piloting the implementation of Inspire in our primary care clinic to evaluate feasibility and integration into clinic workflows. This last project brings narrative medicine directly into the therapeutic space. It's a pilot workshop series I designed and led for adolescents and young adults with anorexia nervosa. The goal was to offer a structured, creative space to reflect on identity, illness, and recovery. This project emerged from both my clinical observations and a clear gap in the literature. We wanted to know, could narrative medicine support connection, self-expression, and emotional processing for youth living with anorexia? AN has the highest mortality rate among psychiatric disorders. Adolescents and young adults face unique developmental challenges in the context of AN, including identity disturbance, a fragmented or uncertain sense of self, and profound social isolation, both from peers and family. While existing treatments prioritize weight restoration and nutritional rehabilitation, they can sometimes overlook these emotional and relational challenges. Narrative-based interventions have shown promise in improving identity and social connectedness in other chronic illness and psychiatric populations, but they haven't yet been adapted or tested for adolescents with anorexia. This pilot study was an attempt to begin filling that gap. Our objective was to assess the feasibility, acceptability, and preliminary effects of a 6-week narrative medicine series for adolescents and young adults with AN. Participants were aged 16 to 25 and were recruited through flyers and outreach to community therapists. Each week, we met for a 60-minute session that included close reading of visual or written art or music, a period of creative expression, and facilitated group discussion. To evaluate the intervention, participants completed pre- and post-series surveys along with an exit interview exploring their experience in the series. We just concluded the pilot last week and have conducted a few exit interviews so far. We enrolled 8 participants in total. 1 did not complete the series due to hospitalization and transition to residential treatment, so 7 completed the full intervention. All 7 who completed the series rated it as enjoyable, relevant, and appropriately structured. From a quantitative perspective, we found a statistically significant improvement in depressive symptoms measured by the PHQ-9 with a p-value of 0.034. Other scales, including identity, social connectedness, anxiety, and eating disorder symptoms, all trended in the expected direction but did not reach significance, likely due to the small sample size. The qualitative data from exit interviews added rich depth to our findings. Many participants spoke about how the series helped them reconnect with aspects of themselves beyond the eating disorder. One participant said, "When I came out of the workshops, I felt a little more connected to myself and became more at peace." Another reflected, "Without the anorexia, I don't know what I am, let alone who I am. So I feel like returning to the other outlets of my identity that aren't around the eating disorder could be very healing." Another described how the creative format helped with emotional processing, saying, I think my writing about my fears through poetry, something that I enjoy, helped me process in a way that wasn't so difficult. It was like an artistic lubricant. Participants also described a profound sense of shared understanding and community. One said, I didn't realize I could channel art and poetry through recovery. I can look at it through a lens of just open-mindedness because art in itself is very open-minded. And hearing about everyone's different opinions and looking at all the different idiosyncrasies of everyone just shows me how complex this eating disorder is, but at the same time, how universal our pain and journey is too. Another quote that came up that I thought was really special and rich was that I've never sat next to many people who are literally going through the exact same disorder I was going through and talking to those people about it in real time. It made it more real and digestible. Even if the group is only 7 people, those 7 people might as well have been the world population in terms of this experience. This pilot offered promising evidence for narrative medicine as a complement to eating disorder care for adolescents and young adults. First, in terms of feasibility and acceptability, we successfully implemented the series in an outpatient setting, and participants came from a range of referral sources. Second, we observed clinical signals, most notably the statistically significant improvement in depressive symptoms, along with directional improvement across identity clarity, social connectedness, anxiety, and eating disorder symptoms. And finally, the narrative impact was clear in the reflections. Participants engaged deeply with the material and with each other. They used the sessions to reconnect with non-ED aspects of their identity, to process grief and fear through creative expression, and to experience the power of shared meaning and community. And this leads me to future directions. As I move into my faculty role, I'm continuing to build on this work in several key ways. First, I'm preparing a K-23 application to support a larger trial of narrative medicine for adolescents, one that specifically targets identity development and social connectedness as a core outcome. Second, I'll be refining and expanding the digital platform to deliver narrative medicine content asynchronously, aiming to make it more accessible across clinical disciplines and levels of training. Third, I'm working on a train the trainer model to build capacity for peer facilitation, empowering clinicians and patients alike to lead this work in their own communities. And as part of all this, I'm eager to forge new partnerships with others who are working with adolescents or who are developing reflective or humanistic programs in education. Narrative medicine is at its best when it's collaborative, interdisciplinary, and deeply rooted in community. Ultimately, my goal is to position narrative medicine as a strategy for reflection, but also for equity, engagement, and long-term healing in adolescent care. I have many people to thank. First, thank you to the Grumbach Award Committee for this opportunity and to my division for all of their mentorship and support. Specific mentors that I'd like to thank are alphabetically listed, as well as collaborators who have been such an important piece of this. And thank you to my funders who obviously were a big reason that these projects were able to come to fruition. And thank you to my dear friends and family who logged in virtually to watch.
That was terrific. Thank you for introducing us to the new world of narrative medicine. And why don't we open this up for some discussion? Oh, we have a nice, this is unusual. We often don't have the certificate for months, but since you are going to be a faculty member here, I don't know if you have an office or a wall, but now you have a certificate. So,
amazing. Thank you so much.
Please, let's have some discussion. Who has questions? Roberta, please.
Thank you. That was such an eye-opening presentation. Question about moderation, and to be clear, I'm very social media illiterate. But is the, I guess, some of these online platforms, like what is the challenge of moderation? How active do people need to be? Because I'm sure it depends. But like I'm just thinking about this in terms the goals of continuing to broaden the access?
Yeah, it's a really good question. And
want to repeat it for the online.
Oh, yes. The question was about moderation, like as we're expanding into these social platforms, social media platforms, and the internet, how we can moderate the comments and make sure that they're safe enough and fruitful enough for people not to feel at risk. The answer to that question with respect to the website that we've developed is, as I'd mentioned earlier, things are behind my access. And that was a big reason for that is on the one hand, we also had to make sure that the works that we were sharing on that page we didn't necessarily have copyright privileges for some of them. And then we were using a fair use claim to be able to display them. And the main reason was that we wanted to make sure that we had a good sense of who was able to post. And I am currently the moderator, so I'm checking. And so far, it's been totally fine. I'm not inundated with posts. That remains to be seen as we continue to grow the platform. But I think, unfortunately, in this very toxic AI glutted world, it can be very hard to make sure that the space stays safe. And for that reason, we're going to continue to keep these safeguards.
It was a great presentation.
Oh,
There's a couple of comments on them and questions on the Zoom. So first of all, Elizabeth Ozer says, thank you for this wonderful overview. And then John Takayama says, congratulations for the Grumbach Award and thank you for the wonderful presentation.
Thank you.
Wondering if there's data that shows that narrative medicine improves the relationship between physician and patient and family. Are there any narrative medicine collaborative both physicians and patients and family?
Sorry, could you repeat the end of that question?
So the question is there data on narrative medicine improving the relationship between physicians and patient family? And are there any interventions that span those groups, both physicians and families?
That's a good question.
Maybe repeat it.
Oh, sorry. Yes. The question was, is there data about the physician-patient relationship being affected by narrative medicine? And also, if there's a triangulation of data with the patient, the physician, and the family? It's a good question. I know that there have been qualitative studies that have looked at this with specifically, I think, in palliative care. They are pretty scattered and I think small studies, but that said, there might be more that I just don't know. So I would have to do an additional literary review to check.
Just to follow up on that, I'm not sure part of the question was, I mean, the intervention seem you can target the providers or you can target the patients or families. Mm-hmm. Do you have the healthcare provider embedded in with the patient or family as part of this, the narrative medicine approach? Right.
So far, as you saw from this presentation, it's really been kind of parallel tracks. That is definitely the next step that I think is of great interest, is how to find ways to make these projects more bidirectional and seeing how, for instance, providers being engaged in this kind of work on the education side translates to better patient care that can be demonstrated, and then how patients being involved in this kind of work could, on the other hand, make providers feel more engaged and invested and less burnout in this kind of in their interactions with patients. One of the ideas that I had with respect to the curriculum, the series that we're doing for adolescents with anorexia, is at some point to be able to have their narratives that they generate over the course of the workshops embedded into their charts. Mm-hmm. This is something that has been done with My Voice, My Life, My Story, which is done at the VA, and has had a tremendous positive impact on both patients and providers. And I think that would be a nice way to make their story and their voice a part of the chart so that they have ownership and that can be shared with the other providers who care for them.
In that respect, if I might just, if you haven't seen it, there was an interesting short piece in the New England Journal of Medicine last week that actually described how AI scribes take all the narrative stuff.
I saw that.
Yes. Out of their transcript, which is almost contrary.
It's so funny you bring that up. So the comment was that the last New England Journal of Medicine was about how AI scribes are really being very selective about what information ends up in the created note, which can really like lose a lot of the richness of the clinical encounter. I think this is a really important point. It was so important that I sent an email to that author because I think it's just something that we need to be very aware of as we're moving forward. AI has a lot of benefits and can do a lot to save us time, but I think there are parts of the relationship that need to be intact and allow us to continue to grow trust with our patients and not to miss the little things that might be edged out. We were just talking in our clinic about how one of our providers had done this whole substance use evaluation, which the AI scribe just completely didn't put into the note. Maybe thought it was counted as chit chat, but it's, yeah, you have to be very careful and giving our feedback to these scribes as they develop.
Following this instance where my wonderful presenting a case dietary management academia, and we were looking at a chart of a really trying to, we're saying to each other, we wish we could capture the feel of this kid. You know, he struggled so much with dieting and he didn't follow the recommendations and he didn't want this medication. And we found this beautiful quote from you, and we ended up just putting it in your note. Oh, yeah. It was a quote that you had recorded from this patient that I really struggled with dieting. I'm trying to do it. I remember thinking in that moment, oh, we are actually all engaged in narrative medicine every time we're writing a chart note, and there's probably so many lost opportunities that someone like takes because you have that perspective. So I learned a lot.
No, thank you so much. I can't repeat all of that. That was really special to hear.
Is the chart a piece of narrative medicine? Is the medical record narrative medicine?
Yeah, I would say yes, absolutely. It's a space where we are making meaning happen in terms of the clinical encounter. And I think it's really important for that reason that we don't delegate that responsibility to other devices, because that's really what gives us, I think, if we're talking about burnout prevention, at least for me, I think that relationship and how we generate it and capture it and represent it can be a really important part of our care experience. That said, it can be really draining. And I will say there are days when I have to continue notes until like 8 or 9 p.m. when I really wish that weren't the case. And it might be that like the editing process becomes more of the meaning making, but I think we have to remain engaged and making sure that we're capturing those little details that really make this person come alive for us.
Yeah. Andrea, you probably haven't seen any of my notes. I think they read like fine novellas. Could I ask you a question about age for benefit from this? Have you explored lower age? I'm just curious about whether we might miss the boat with children with chronic illness who might be able to benefit a lot from this type of approach.
Yeah, absolutely. I think that the question was heard. I think that the waiting room project, for instance, was one where most of the patients who participated were between like 4 and 10, and they had a really wonderful, joyful experience of being able to create art and write those who could write some stories that they could put onto the walls and really shape the space in their words and images. And so I do think that this can translate across the board, even with like infants, parents. I think there's real value in these opportunities to create meaning and build community at every stage of life.
A couple of questions. One, many unhoused people are adolescents. What potential role do you see for narrative medicine working with that population of people?
I think it's a really good question that how do we incorporate narrative medicine in the care of adolescents who are unhoused? Honestly, I haven't had the opportunity to work directly with that population. It's definitely one that I think would benefit, and I would love to. I think it's an important next step for the field if it hasn't been done already.
And then Liz Seashore also says congratulations on your work. Have you thought about how you might want to build and grow narrative medicine for the residents and fellows in our programs over the next years, and what needs to accomplish that?
Yeah, who said that question?
Liz Sure, I think she's volunteering.
Oh, Liz, great. Yeah. The question was just how we're going to expand narrative medicine for the residents and here at UCSF. We do have a plan. Slated, we're going to have 5 or 6 sessions over the course of the year ahead. And I'm still working with Cho as well to be able to bring this to them too. Unfortunately, what I had presented was a cross program collaborative model. But with scheduling being what it is, it's been challenging to uphold since. So we still want to make sure it's accessible to both sides, and it's in the works.
I'm sure Liz, in her role as team lead for well-being.
Yes, I would love to work with Liz.
And then one more is the June 12th session for the narrative medicine circle, the last one, or are you planning more than that?
We're planning more. That's also TBD. But if you're interested, reach out, and we will also be doing our best to spread the word. Yes.
Build on what Andrea brought up earlier, and I think the other thing that came to mind as you were talking about our charting as an active narrative medicine is I think that has become much more, it actually gets at Steve's question too, bringing the family and the patient into the conversation now that we have open charts. And thinking about that form of narrative medicine and the expression that comes in that interaction, and maybe having that be a place for future research as well.
Yeah.
What is that? What are they receiving from us as they see us tell their stories? How does that change the way they describe?
Yeah, that's such a great point. Yeah.
Qualitative study?
Yes. The comment was that as we're in this open notes world now, there's so much more, like the patient now has access, the family now has access, and there's a witnessing of our story and our documentation that kind of complicates the picture, but also is an opportunity for us to think about co-constructed meaning. Hey.
I had a question about like parents, like how do you include their narrative too, especially sometimes if there's like a conflict of like the narrative, like maybe a young person is saying something and then the parents telling you another thing. Like how is that like, how does that have its place in narrative medicine?
Yeah, that's a great question. Being that how to navigate the parent-child dynamic in narrative medicine, and especially when there's conflict. So I would again allude to the podcast that I had created. It was called Choni Core. And the premise was that it was a conversation. If you're familiar with StoryCorps, which is what kind of roots this work, it's basically a conversation between two people who know each other well with like some guiding questions. And in the course of creating that podcast, we recruited parent-child dyads that weren't always harmonious. And it was just incredible how like creating this space where there's another level of conversation where they can have these deeper discussions about meaning. Like I kid you not, every single episode we were all crying by the end, and I think it was very illuminating for them, and an opportunity too for parents to be able to give space to their children to be able to voice everything, and to be able to honor them by telling them. One of the questions in the suggested, which everyone answered, was like, tell them what they mean to you. And I think without having those prompts, it can be very easy. One of the episodes was all about the patient and parent saying that like in the course of chemo and treatment and the day-to-day, it's very hard to have conversations like this. And yet this is like the most meaningful thing that's happened for them this month, like that kind of thing. And I think just generating spaces where that's possible in healthcare, I think is a really important opportunity.
One last question.
I am thinking back to, I think it was right before we moved to Mission Bay, there was a project that our Child Life team was doing. I think it was called 1,000 Journals, the national project, if I'm not mistaken. And you can see some of the pages from that on MedSearch back by rooms 15 and 16. And it's making me think that so many of our child life specialists have been engaging in narrative medicine for as long as we can remember. And so I'm wondering about working in a multidisciplinary way with those specialists who spend so much time at the bedside.
Yeah,
in between, you know, our therapists and our regular child life specialists.
I totally agree. The statement was that child life does so much narrative medicine just by virtue of their practice. And I think narrative medicine, I'd alluded to like interprofessional collaboration. I think this is the space where everyone can contribute. And they certainly have a lot of expertise to teach us. And yeah, all of the projects that I did in residency had very much a strong child life involvement because they get it. Yeah.
Thank you so much.
Thank you.